Hey everyone, welcome to the Straight-Talk Physio Podcast with your hosts, Dr. Andrew Junak and Dr. Craig Giambattista. On today's episode, we're going to talk about what the benefits of an Xray are, and we're going to kind of go through some of the detailed stuff about why other providers may recommend X-rays and what physical therapists actually do with X-rays. So we're going to kind of start from the beginning of this with what is an X-ray and what does it show. So Craig, you want to kick us off?
Yeah, sounds great. So just starting off, I think it's important to know, we'll just do like a little defining here, what exactly an X-ray machine is. So basically, when you go in, it's this big, complicated looking thing. And the point of an X-ray machine is to produce this controlled beam of radiation. And basically what it does is it's used to create an image inside of your body. So what they do is they'll kind of point this thing at the area that's being examined. And after this beam of radiation goes through the body, it kind of falls onto a piece of film or like this special plate where it'll kind of cast a shadow. The reason the shadow can be cast is because different tissues in the body will block or absorb the radiation differently. So that's kind of why we get to see what we get to see. So dense tissue like bone, it blocks a lot of that radiation. So it appears like pretty clear and pretty white on the film there. Other stuff like soft tissue stuff, so muscles, ligaments, tendons, they're not really good at catching that beam of radiation. So it comes up pretty dark, and you often really don't see them. So often what they'll do is they'll take a lot of images at maybe like some different angles to kind of get like an appreciation for what they're looking at, because it's kind of just like a two-dimensional image. You know, it's just picture it, you kind of seen at one angle on the paper there. So when you get this done, that's why if you have a bunch of, if you look at your healthcare bill or your doctor's notes or whatever, what they might see is you might see a lot of different angles on these X-ray, and that's kind of the reason they're doing it, is they want to try to kind of create this 3D image in their mind, kind of what's going on. So in the very basic sense, that's kind of what the X-ray is. As far as like defining it, any other things you'd add there, Drew?
You know, I think you hit the nail on the head. It's just basically there to give us a picture of the bony structures. It doesn't do a great job at, most organs and, pretty much any sort of soft tissue structure, muscles, tendons, ligaments, but it does visualize bone very, very well. So that makes it a pretty good screening tool when we're looking at bony issues. And some of those bony issues may be fractures or abnormalities. So if we're kind of move on to what it's good at finding, we have like fractures, as mentioned before, the bony abnormalities, some kind of more serious things like hip dysplasia, avascular necrosis. For people who have maybe a blood clot that travels to the lung, if you go to the ER, you may find that they'll do a chest X-ray. They're just making sure that you don't have what's called like a pulmonary embolism. A lot of times orthopedic providers will actually use it to see if somebody's dealing with any sort of arthritis, like in the knee. Very commonplace to have X-rays taken in the spine, so the lumbar spine or the low back, and then also the neck or cervical spine. If a patient was in a motor vehicle accident, a lot of times an X-ray will be done with the mouth open to make sure that some of the upper cervical spine bones did not crack or fracture. So those are some of the main cases that X-rays are being used. Anything to add to that?
One thing I think that we could also talk about is sometimes physicians will get an X-ray, sometimes to assess change. A good example, I think, would be in the low back. Sometimes patient language, you might hear that one of the vertebrae in your spine has maybe shifted a little bit, one way or the other. We call that a lithesis. So sometimes they'll take a picture of it, and then they might want to see it a couple months or years later to see if it's moved, to help kind of diagnose like a functional, like a mechanical instability there. So I would say that's another time that you might see an X-ray. So one thing we'll kind of transition to next is, so when should we use, or when do these become sort of valuable to us, I think is kind of the topic of our presentation here. And I guess I'd start out just kind of saying that we are not against X-rays. There's absolutely times to use it. I think where we'll spend a lot of our time today is kind of the middle ground of when we see a lot of X-rays used. On one end, the traumas, the motor vehicle accidents, the falls, absolutely. We want to screen those things out, or the medical complex things, the avascular necrotic hip, like that kind of stuff. absolutely warranted. 100% get them, do them. But today, what we're going to be talking about is that middle of the road, non-specific musculoskeletal pain. Like, you know what, my back has been hurting for a couple months, or my knee has been bothering me for a year. You go to see your primary care doctor, and every time, the first thing that's going to happen is you're likely going to get an X-ray. And of course, the screening is nice. But I think the problem that we fall into is there's going to likely be, after you pass a certain age, there's going to be some bony changes going on there. And that's normal. There's something we call Wolff's Law in our profession. Basically, it means if something is stressed, it will adapt to that stress and it will change. You know, our body is kind of always in this cycle of breaking down, rebuilding, breaking down, rebuilding. And kind of simply put is, if you use something a lot, it will change appropriately. And on the other end, if you don't use something a lot, it will also change, appropriately in that way. So where we get into problems is these, what we would call them maybe like an incidental or just like an artifact finding on the image. And then as the patient, you're told that there's all these things going on, or you have a collapsed disc, or like a bone on bone kind of knee. So that's what we'll be spending a lot of time on today, is what does that mean for you as the patient? So anything to add to that one, Drew?
I think you covered a lot of it. I think the key things to hit on is probably when it's most appropriate to have an X-ray. If you go in for just muscle, tendon, ligament, bone pain, and you're just not sure what's going on, and somebody does an X-ray for an orthopedic injury, many times that X-ray is going to come back negative. For us, I think what's more important when I do like a phone screening with a new patient is learning whether or not there was trauma involved. Did they have a fall and land on their shoulder? Did they get hit by a car? Was there a motor vehicle accident involved? Because if so, there could be a fracture, there could be a break in the bone. Something could physically be in a different alignment, and it needs put back into place. A dislocated shoulder. I was at a CrossFit competition, and a patient had a dislocated shoulder doing a 1 rep max snatch. And, immediately the first step is go to the ER, get an X-ray. That is an absolute must, because they need to reset that shoulder and put it back in place. And they need to make sure that no fracture occurred in the meantime. In the cases of somebody who's elderly and they fall, land on their shoulder, land on their hip, it's important to make sure that they didn't break a hip, didn't break their shoulder. But for typical orthopedic injuries, like I rolled out of bed and my neck was hurting, or I was going from sitting down to standing up, and for some reason, I got this shooting pain in my low back. Things like that, we really don't need X-rays because they don't give us much information. Oftentimes we find, like you mentioned, that artifact sign where things come up on the X-ray and it looks like it might be positive or have something to do with the diagnosis. But in all honesty, it really has nothing to do with the pain that they're experiencing. So from an X-ray standpoint, I just don't think they're all that valuable to physical therapists. And, we'll talk about a couple different areas of the body that we see this most commonly. And, do you want to start with that, Craig? You want to take the lumbar spine?
Absolutely. And this, a topic that I am passionate about here. So if I get on my soapbox here, if I get hot about it, you just, pull me back here.
I'll try to cool you down. It doesn't always work though. I'll do my best.
The biggest thing, I guarantee at least once in my day, someone's going to come in with back pain that they've had for a long time. I'm talking 6 months plus. And at that point, they have probably received, the gamut of imaging. And I think the one thing that sticks out to me is they'll come in and say, you know what? I got degenerative joint disease. My spine is crumbling. It's falling apart. That's what the X-ray is showing. And I think that just that terminology there, that sounds bad. Like if I had no medical training,
scary, right?
I was told my back is crumbling and falling apart, like I'm obviously gonna think the worst there. And that's reasonable. I think that's very reasonable.
Real quick, what's the word they use? Degenerative? It's degenerating. They could choose a nicer word, right?
Pretty much anything but that, I think, would be probably appropriate. That would probably be good. My favorite, little piece of research, because we do want to keep this a little bit evidence-based. that I like to bring up is there was a study that was done a while back, and they took a bunch of patients, just normal people, no real back pain, and they said, you know what, let's do a bunch of imaging on them, and let's just see what we find. Let's see kind of what comes back out. And what they seem to think is, and tune into our MRI episode because we'll talk about this a lot there too. But after a certain age, once you kind of hit middle age, and as you get older, the likelihood of having, quote unquote, degeneration found on a radiograph or an Xray of the lumbar spine is better than half. And once you kind of eclipse that like 70, 80-year-old age, it's like 80 or 90%, or maybe even a little bit higher. So that kind of begs the question, why do we see these, what people would consider, severe changes in maybe a person with no pain, like
Right.
that's tough for, I think, even us as skilled rehab people to kind of work out why that's even happening. So I think the bigger question we got to ask, or things that we got to realize, is as far as osteoarthritis is concerned, we don't have really a great handle on it, because if we fully understood it, then there would be like a definite fix to it. I think we're still in the process of kind of finding out what we have a good idea how to treat it pretty effectively, but I think that definite underlying physiological mechanism is there's still a couple questions there. We might kind of get there. But I think that's the important thing to realize when you do get that imaging is, if you spend a lot of time reading the research, there's a lot of stuff that will disagree and say that the imaging finding regardless doesn't really correlate to pain. So if there's a big structural change, does that mean there's a big increase in pain? Depending on who you read and how much you read, you can make the case and say yes, and you could also make the case and say no. So I'm not here to talk about who's right and who's wrong, but what I am trying to say is, if there's that much variation, you have to understand that we don't really have a great handle on it. So I don't know if you have any opinion on that or anything you'd like to add.
Yeah, I think the biggest thing here is what we see clinically, right? The clinical exam and the image itself has to match up. So if somebody gets an X-ray and they have all this arthritis, and one of the hallmarks of arthritis is stiffness, like the body just does not move into certain positions, or they lose a lot of range of motion within a joint, whether that's the spine, they can't bend forward, they can't bend backwards, they can't bend in any direction. If it's in the knee, they lose the ability to bend their knee and straighten their knee all the way. And we're talking like not just a little bit, we're talking a pretty good chunk. Like there's a lot of motion that's missing there. And then there's pain associated with it. But the exam, there's a lot of other things that we're looking for, but that's just one component. But there's many times where people will come to me with these X-rays that, it's a severe degenerative disc disease or severe osteoarthritis between these few joints. And then we go through our exam, and really the arthritis isn't causing the pain. And I think that's one of the big points that we want to hit home today is, I saw a patient the other day, for example. He came in, he has knee osteoarthritis. He's in his mid 60s. And if you were to take an image of every part of his body, like his wrists, his elbows, his shoulder, I can tell you right now, you'd find some arthritis. He only has knee pain. So for some reason, that knee is reactive and it's causing some of his symptoms. But if you were to really, like I said, take an image of anywhere else on the body, he does have arthritis and he doesn't have pain. So what we find from these images is that just because you have arthritis or you have some changes on the image doesn't necessarily mean that it's not an if-then relationship. If arthritis, then pain. It's if arthritis, there's a small likelihood that you could actually have pain. So we're seeing a lot of people get total knee replacements and knee scopes and things like that, when in many cases, all they need to do is just move better, get stronger, and go through a little bit of rehab, and that pain will most likely go away and the range of motion will come back.
Yeah, I agree with you 100%. I think one thing that we fail to forget, and this happens to me sometimes too, is really how complex everything is down there. It's not like the knee is not just two bones together that just happen to move. There's so many other things. There's ligaments in your knees, there's tendons, there's muscles moving it around, there's the joint capsule. It's highly innervated by the nervous system. So you have all these little nerves sending a lot of information to your brain about it. And I think the reason that it's easy to get attached to that image and what it says is like, it's simple and it makes sense.
Yep.
And we want answers, you know, like,
and you know what? You can see it very easily on that X-ray. You look at it and you show a patient and they've never seen an X-ray before. They can look at it and say, oh yeah, that looks bad. I can see how there's not a lot of space there. It's easy to see.
Especially when you have like, you see a picture, okay, this is normal.
Yep.
And then next thing you know, here's your picture next to it. And you're like, well, that doesn't look like that, you know, like, well, like what's going on kind of deal. And I think that it's easy to attach to that small singular piece. And I think you hit the nail right on the head earlier when you said that it's all got to correlate together. Like there's got to be a nice cluster of things. Like rarely in the medical world, I would say, you know, a physician, occupational therapist, physical therapist, you know, you name it. It's always we're most accurate when we can cluster things together. Like rarely are we going to just hang our hat on one thing. And I think as a patient, that's important to know. So I would say if there was one thing you could speak a little more to, because if we talk about, you know, the crumbling low back being one, the second thing, or maybe even as equal as I hear is like my knee is bone on bone, come in day one. Okay. You have knee pain. We do this great exam. And then at the end I hear not going to be able to do anything. My knee's bone on bone. So what do you say when you hear that?
Well, when I start with my exam, the first thing patients who've usually had an X-ray, they're like, hey, I have my X-ray. Do you want to take a look? And I'm like, nope, I don't even want to see it. And that just kind of tells you how much information it actually gives me. You know, overall, I think X-rays for me are most valuable. If that patient's already coming to me and they've had an X-ray and it doesn't say that they have a fracture or anything more serious going on, then that X-ray almost means nothing to me, because for me, I want to do my exam first. I don't want to see what the picture looks like and then, you know, kind of have that bias me or change the way I look at that patient. So I'll go through my exam, but all the time patients come in and say, oh, I'm bone on bone, or in my back, I have no disc space. It's bone on bone. But what's interesting is, you know, when that patient responds to rehab, if they decide to go through with rehab, which usually I'm eager to have them at least try. And the reason being is because if I can help them before they get to a surgeon. And again, I'm not anti-surgery or anything like that. There are definitely cases where people need surgery. But many of these cases, they just don't. They don't need it, or they don't need it at that time. Maybe it's 5 or 10 years down the road, but right at that moment, they're not always a surgical candidate because they're bone on bone. But essentially after the rehab is done and, you know, said person's feeling a lot better, they can move, they have the range of motion back, they're back to doing all the things that they love in their life. You know, if you go and take another X-ray, it's still going to be bone on bone. The image in the picture is going to look exactly the same. There's going to be no difference there. But the difference will be clinically in how the patient feels, how the patient moves, and in their pain levels. So I think that's one of the other key things that we see is we're not changing the structure, but we're changing the sensitivity of what's actually going on. And if arthritis isn't the initial driver of the pain, then yeah, we are solving the problem because it doesn't have anything to do with the structural changes that, you know, we're seeing on that X-ray.
Yeah, I like that a lot. I think one of my favorite analogies or little sayings I like to use, and I completely stole this from Tim Flynn. So if you ever listen to this podcast,
thief.
Awesome. But it's like, and he said, I think I've listened to him say it, and he said he learned it from somebody, and that person probably learned it from somebody. So whoever deserves the original credit,
props to them.
But it's such a good one that I'll try to bring it to light here. So what I kind of tell people is, I'll say we can't see inside our body, right? But the stuff we can see, we are okay with it structurally changing. Or having some tissue change. And the example I'll use is as you get older, you start to notice like wrinkles on your forehead or wrinkles on your cheek, right? So there has been a definite structural change in the soft tissue of your face, which years ago was not there. You don't have chronic face pain. No one's face always hurts, right? There was a wrinkle there. The structure has now changed, but that's okay. you're not just all of a sudden popping up with
Right.
chronic face pain. That's just not how it works. The same thing can happen to the knee. We just can't see it.
Yep.
So I typically like to say on these imaging findings, it's like a wrinkle on the inside.
Yep.
And I think
That's a
people
great way to say it.
tend to resonate with that one. So I don't know if you have any good sayings or because I think a good way, at least patient-wise, is I think we take for granted as PTs, medical professionals, that we know all this stuff. Like it makes sense to us, but on the other end, the patient end, they've never really heard anything like that. And it's hard to just like sit down and over 5 minutes explain what we just went through. And then the light bulb it's hard for that to click,
Yeah.
So I'm just curious if you have any other pieces of education or things that you've seen worked, or just kind of how you address the learning part. Cause I think that's kind of the first line of defense for this stuff.
The biggest way I address it is I talk to people about age-related changes. Every day we are growing older, and from a lot of the research, and I believe it's actually in the study that you were talking about earlier, if you're over the age of 25, there's some arthritis within you. Okay. It's happening. Your bones are aging. Your cartilage is aging. All these different structures, they're aging. Some of the other structures are ossifying, or they're stiffening up, like your ligaments, those sorts of things. So, the best way that I describe it to patients is this stuff is normal. Like you're getting older. But just because you're getting older, it doesn't necessarily mean that it has to cause pain. So, and much of the time I'm spending, talking to that patient about how there's arthritis. Like, do you think you have arthritis in your wrists too? They're like, well, yeah, it's stiff in the morning. Like, do you have pain? No, not necessarily. So I'm just kind of trying to, with that patient that I'm, communicating with, explain to them that it doesn't necessarily have to mean that if arthritis, then pain. And just getting the idea that arthritis is normal. Like it's just a part of aging. It's a part of life. And to some extent, it doesn't always have to be the driver of pain. Some people like to blame their pain on that. But I'd say 9 times out of 10, that's not the only driver or the only thing that's causing the problem itself. With that being said, I kind of want to switch topics and touch on one last area, which I think is really interesting. The topic of spondylolisthesis or spondylolysis. So to give you a little background on what that is, anywhere in the spine, so it could be in the neck and primarily in the low back, these are the 2 common places that we see it, we will actually see if you take an Xray and a sagittal image, or like what we call basically an image from the side, you can appreciate whether or not the vertebrae are in alignment. Okay. Well, what can happen is if one vertebrae has what's called a spondylolisthesis, this is considered like a slippage of the vertebrae. So it will actually shift a little bit further forward on the one above and the one below it. And this is completely different than when, a provider says you're out of alignment or something like that. That's a whole nother discussion that we'll have to have. But this is a little bit different than that. And sometimes patients will have a motor vehicle accident. And, in the ER, they'll go through and they'll do all their assessments. So they'll do an X-ray, sometimes a CT, sometimes an MRI, and they'll find this slippage in a patient that doesn't have any back pain. And so a lot of people, they get hung up on, oh, geez, I have the spondylolysis or the spondylolisthesis, and these different suffixes to the word, it just denotes how bad it is. So a spondylolysis is a less severe version of a spondylolisthesis. So there's less slippage in a spondylolysis, more in a spondylolisthesis. And oftentimes physicians will want to monitor it, but most of the time patients with this don't have any pain at all. But the second they hear it, their initial thought is, oh, geez, something's really wrong with my back. It's slipping out of place. Like I'm going to have a disc problem in the future, or I'm going to have, all these issues, or my back's unstable. I start to hear all these different things. And I think this is a good time for us to clear that up too. What do you think, Craig?
I agree. And I think one thing worth noting is like when you hear the fancy word, if you have no background and you get sat down and say, you know what, you have a grade 1 spondylolisthesis or a grade 1 retrolithesis or whatever, it's like that sounds
pretty
strange,
scary.
So like, and I think a small, and this could be a whole different topic for a whole nother day, but if I'll tell patients that that sounds fancy because it's a medical term and it's a short form of us knowing like what it is. So and I'll do this all the time, is when you see all these words on imaging, I'll just break it down. I'll say like, so the Latin, so spondylo is just a Latin root word for vertebral body, and lithesis is just a Greek or Latin word that means slippage. And the grade is just a way to describe the measurement of how much it is in millimeters. So millimeters, this. So if you break down that big fancy medical word into its component, it just means that the vertebral body, so the piece of bone, has made a millimeter slide in one small direction. But it's like, who wants to write all that down? So we try to make, I don't want to call it like a shortcut, but it's a good way to describe all of that in just a few words. But so you don't have, the radiologist out there just grinding away, typing like vertebral body has slid this way, this many millimeters. That would be inefficient and take forever when we have like these cool words that can kind of make all that stuff up. It's like, medical terminology is like learning a second language, like the words sound fancy because they're just shorter forms of maybe long sentences. So oftentimes in imaging, I'll say, let's break some of this stuff down, because all these fancy medical words are typically just a descriptor of what the image shows.
Absolutely.
If that kind of makes sense, even if you see like your mild, moderate, and severe degeneration, it's like, I always say that like change on the radiograph, it needs to be graded in some way. You can't just say, I don't like the term degenerative, but that's what we use. But you would obviously want the person looking at the picture to know, is it a lot? Is it kind of a lot? Or is it, just a little bit? I think that our word choice is bad. I think it's good that we describe it because you have to be specific and you have to know what's going on. But I think the language we use is not appropriate, because when you don't know what it is, you associate it with something negative because it's a negative word. Degenerative
Right.
is a negative word.
Very negative word.
Yeah. So I don't know if you have any thoughts on that kind of stuff.
Yeah, I think you hit it on the head there too. Like when I'd say probably 10, 15, maybe 20 years ago, patients didn't have access to their chart. They couldn't actually read through their chart on their own. So a lot of times they'd get a phone call back from the physician office, and they'd say, we looked over your X-rays or your MRI, your CT, whatever image it was, and they'd say, yeah, everything looks great. And then, the patient would roll over, sleep sound at night, and have no troubles. Nowadays, patients have access to all of their things online. So many times, a physician office might forget to call them. They might just want to see what the image says on its own. And when you take a look at what the radiologist said, boy, does it look scary. Like things are degenerating. There's different grades on there. There could be, other big words. There's millimeters of slippage. When they grade degeneration, sometimes they don't grade it with numbers. They call it mild, moderate, or severe. So when somebody hears I'm severely degenerating, that does something to you. So I think at the end of the day, now we are way more informed about our healthcare. And sometimes when patients pick up their chart and they say, hey, I want to know exactly what's going on, these X-rays, they don't just say negative. It might be a negative X-ray, but there's still a report on what's going on at every one of those joints in the lumbar spine. There's still a report on all of the disc structures in the lumbar spine. So even though at the very bottom it says, clinical finding or examination findings negative, there's still this 1 to 2 page breakdown of all the things that sound like they're wrong with you. So it's very easy to get hung up on that, but really at the end of the day, what we're looking for, has some to do with those findings, but also quite a bit more to do with the exam that we find, because our exam itself is what really drives our care, not the picture.
Yeah, I definitely like that. And just to kind of, wrap all this stuff up, I guess if I had to put my little stamp on this one, and again, just like last episode, if you didn't listen to anything and if you tuned in at the end, and if you want like the too long didn't read version, I'll give it to you here.
Here it comes.
So first and foremost, X-rays are important. Right now, me personally, I could confidently say if something seriously is going wrong, the X-ray is the gold standard to find some serious stuff, and it's absolutely useful in those times, but like I said, it's tough. I believe the jury is still out when it comes to non-specific, chronic that gray area musculoskeletal pain we just talked about. Remember that age-related and tissue and bone changes are normal as you age. What becomes abnormal is when that specific area starts to be painful. Does it have to be the joint or the bones? Sometimes yes, sometimes no. That's why you come to people like us. That's why you go to your primary care physician, and we tend to figure that stuff out. As far as research is concerned, joint pain responds very well to exercise, various modalities, and all the other good manipulation, dry needling, et cetera, that kind of stuff that we do. And that's why I think that we don't want to get hung up on the image, because it only tells a small part of the puzzle. We want to take a look at overall function. That's our goal.
Absolutely. So in wrapping that up, thank you guys for tuning into the Straight-Talk Physio Podcast. If you like what you're hearing, it would mean the world to us if you subscribe to this podcast and the Peak Physiotherapy and Performance YouTube channel. For more information about us or to follow the podcast, please check us out on Facebook at Peak Physiotherapy and Performance and on Instagram at P3 Physiotherapy. Thanks again for watching, and we hope you have an awesome day.
See you next week.